We'll start?
Yes, sir.
Right. Now, Shiva, you ready?
Yes, sir.
Right. So we'll start. So good evening, everybody. Welcome to this evening episode of Pursue. This is for Pursue 4G, which is GYN Path. And we are streaming live from TMH Mumbai via Kolkata. And today we have a very interesting slide seminar in gynae pathology. And we have a very important speaker and a very important moderator. I would like to introduce the moderator. The moderator is Dr. Suma M.N. She's an associate professor of pathology at Kidwai Memorial Institute of Oncology, Bangalore, an expert in gynae pathology, and she will be moderating. I would request her to introduce the speaker and take it up from there. Ma'am, please take over.
Good evening, everyone. Thank you, sir. Thank you very much. As sir said, today we have a very eminent speaker with us, Professor Santosh Menon, who is a professor of pathology at Tata Memorial Center, Mumbai. He has a total experience of 17 years in the field of oncopathology. He has special interest in uro oncology and gynae oncology, and he is in the disease management group of these two specialities. His areas of interest being oncopathology, uro-oncopathology, gynae-oncopathology, and immunohistochemistry. We are all looking forward for a very interesting slide seminar from you, sir. Over to you, Santosh, sir.
Yeah. Can I share my?
Yeah, please.
Sure, sir. I hope you can see my slides.
Yes, we can.
Is it full screen now?
Yeah.
Yes.
Thank you very much, Dr. Suma, and thank you, Nadeem sir, for having me here for this gynae slide seminar. So, as slide seminars are generally, they are difficult cases, interesting cases which you may encounter once in your lifetime, or once difficult cases which you come across in your practice. So I labeled this initially as interesting gynae path slide seminar, and then I looked up some similes or similar words to interesting, other ways to say interesting. It may be similar to fascinating, striking, intriguing, engaging, absorbing, or diverting. I hope at the end of the session you feel that some of these words do count for this slide seminar. They are difficult cases. You may not have seen them. You may have heard about them, but not come across them. But then they are somewhat interesting. So I removed the word interesting from that for you to decide whether they are really interesting or not. I'll directly go on to this case, the case number 1. The history which we had was a 47-year-old female with abdominal pain and distension of abdomen since 3 months. She had on and off abdomen pain since many years. That's what the history was mentioned actually. And they did a CT abdomen and they found that there was a 13 to 20 centimeter mass. I really don't understand how somebody can carry such big masses within the abdomen. So that probably was growing for many years, and that's why she had on and off abdomen pain, which she disregarded. CA125 was mildly raised. It was not very significant. There was no metastasis in the omentum or peritoneum. So these were the CT findings and the serum tumor markers, and her age was 47-year female. They took her up because she had a large mass and they wanted to take it out and find what it is, see what it is. It was a large mass on intraoperative frozen section. As other ovarian masses, it was also a solid cystic mass, soft to firm, edematous, hemorrhagic. There was some kind of infarction on frozen section which you could find, which was confirmed also on microscopy, and we thought that there was a torsion. So if you have a 30 centimeter mass, which is probably ovarian in origin, it's imperative and it is almost sure that it would have undergone some kind of torsion somewhere. The frozen section diagnosis was query sex-cord stromal tumor because they found some spindle cells. I'll show you directly go to microscopy. I don't have a gross image of this case. So this is what we found on microscopy. You can see that these were the spindle cells which were actually seen in frozen section and called as possibly sex-cut stromal tumor. But if you look at them, they are very pink in color. There is some hyalinized tissue here in between. Otherwise, these spindles will look very pink at this power. They don't show too much pleomorphism. They look rather monomorphic. But yeah, the cytoplasm looks pretty much pink. Other areas showing more rarefied areas, rarefaction with these kind of uh, bubbly appearance with these spindle cells, some kind of vacuolated cells you may find. Again, a lot of hyalinized areas in which these nodules of spindle cells were present. The striking feature is the very fiber-like appearance of the spindle cells and the pink cytoplasm set. At higher power, you can clearly see that they are very rhabdomyomatous in appearance, very pink, bland looking nuclei, a little ovoid to spindle nucleus, a faint whirling kind of pattern, but long, slender, fiber-like appearance or a rhabdomyomatous appearance, or what you can call as a strap cell-like appearance was seen. Now, other areas were totally different. So these were unfortunately not sampled at frozen section. If you look at this low power picture, you can see that there are some nodules. They look very palisaded nodules with palisading of cells. Some very obvious tubules were seen. Some very monotonous blue looking areas were seen. And then these are tubules and aggregates and congregation of tubules which were seen. At other areas, you can find that these are again the same areas looking very blue. It mixed with those pink areas. So those pink rhabdoid or rhabdomyomatous kind of areas, which you saw, were admixed with this blue looking areas. Another field to show that these kind of areas, there are some tubules again which you can appreciate at this power, along with those pink rarefied and spindly areas with admixture. At higher power, these look very blue round cell tumor like appearance, very blue, not much to appreciate about the pattern here. Again, directly emanating from these blue blastomal kind of appearing areas, you have these spindle cells which we had seen earlier. Again, you can appreciate some tubules here. Again, another picture to show similar areas with tubules, very small blue round cell areas, and these pink spindle tumor areas. Higher power to show the palisaded tubules, very palisaded appearance, and then you have a little glomerular appearance at places, tubules, some spindle cells in between these tubules, and these little undifferentiated blastomal appearing areas. More pictures to show similar areas. You can appreciate the tubules, the fused tubules, the spindle cells, and some blastomal areas. We took several sections. It was a 30 centimeter tumor, and this was in a couple of sections only we could find some epithelium with mucin, some mucin within the lumen of these cyst-like areas. This is again another area to show that there was admixture of these blastomal kind of areas or the blue areas with these mucinous areas or mucinous epithelial areas. Higher power to show that these are almost looking like gastric or endocervical kind of epithelium. Along with mixed with those kind of blastomal as well as those pink tumor cells. Very focally we could find a flattened lining like these other epithelial areas, and only in one section we could find cartilage and some calcified cartilage like areas. So this was a strange tumor. We had never come across this previously in our setting. So what we did Desmin, which confirmed the rhabdomyomatous or rhabdomyosarcomatous areas, very nicely seen in these two pictures that IHC is highlighting. You can see that those blue blastomal areas, the tubular areas, are totally negative for them, and myogenin was also positive. You can see the tubules which are dead negative here, whereas the spindle areas of rhabdomyosarcomatous origin are myogenin positive. The blastomal, tubular, and the spindle areas were confirmed with WT1 stain as Wilms tumor because the proper triphasic Wilms pattern I've already shown you with tubules and the blastomal elements as well as the spindle elements. So that was confirmed with WT1. You can see how the tubules are nicely marked, the spindle are marked, and the blastomal areas are nicely marked with WT1. Another area to show the WT1 positivity. CD10 was also positive in these tubules, again to show CD10 positivity in these tubules. Paxate was negative in these areas. So this is an unusual case of an extrarenal teratoid Wilms tumor of the ovary along with rhabdomyosarcomatous elements. This is an extremely rare entity. Extrarenal teratoid tumors, extrarenal Wilms tumor are well known, About 70 to 80, I think 70 to 100 cases have been described in literature, but in ovary they are not very common. And even more rarer is the presence of teratoid elements. So you may have a pure extrarenal Wilms tumor in the ovary, but with the presence of teratoid elements, they are even rarer. There are only few case reports in the literature which you could come across. So there is some theory behind these that there are two types of extrarenal Wilms tumor. One found as components of teratoma, which is teratoid Wilms tumor, or one which can be purely Wilms tumor and in which you may not find any teratomatous elements in the ovary. And the teratoid Wilms tumor is the rarer of these variety. There are certain theories that they arise from persistent mesonephric ducts, or then there are certain embryonic stem cells which are present, which have the potential to develop into any, which is called the Quanheim's cell rest theory. So these are certain theoretical things about these. These are extremely rare tumors. And I could come across some literature regarding this. This is a series published in Gynecology Oncology Reports. There are 5 cases of extrarenal Wilms tumor, and I think one of them was in the gynae tract. And this is a 2020 June paper from Memorial Sloan Kettering, which just talks about 2 cases. And they said that teratoid Wilms tumor in the ovary, there are only 2 reported cases in the world as per literature. So this was an unusual case. Any questions on this, Nadeem sir or Dr. Suma or anybody?
Interesting, sir. Interesting. The thing is, sir, I just have one question here. When we say rhabdomyomatous differentiation versus RMS, what is that? How do we differentiate that? The differentiation does not have myogenin, and only the rhabdomyosarcoma component will have myogenin. Is it so?
Generally, rhabdomyomatous would be a more rounded and more skeletal muscle, like just as a cross section of skeletal muscle you see. That's how usually a rhabdomyomatous look. Generally, in a teratoma, if rhabdomyomatous differentiations, I'll take a line from the testis here, testicular tumors. Post you may find a lot of rhabdomyomatous element. They are myogenin negative, but they look they are desmin strongly positive, but they are very differentiated looking skeletal muscle. So that is very well known in post chemotherapy testicular germ cell tumors. In the ovary, these are not well documented because germ cell tumors are very rare in the ovary, and this is extremely rare finding in this. So here it was clearly I failed to mention that here the MIB1 was very high in these areas of these proliferative both rhabdomyosarcomatous as well as the Wilms tumor areas. So this was a Wilms tumor along with a rhabdomyosarcoma, which was admixed and on a background of a teratoma. So she probably had a teratoma long standing from many years, which she had ignored, slow growing, and then suddenly this has developed as a somatic malignancy in this.
Okay, that's great. Thank you, sir. Any questions? I don't see anything from the chat box here. So I think we can go on to the next.
There are a lot of people on the YouTube.
YouTube, sir.
Yeah, let's wait and see if there is any questions.
I think those who are here live, they can unmute themselves, and if they have any doubts, they can ask.
Okay.
Isn't it, sir?
Yeah.
Santosh, very nice case. Dr. Sandhya here.
Yeah, your voice is so characteristic, madam. I can.
The thing is, Santosh, you said somatic malignancy. Now, how often do you see this kind of somatic malignancy in ovary? I understand it's very rare, but is it usually like this rhabdomyomatous differentiation that you get just like in testes, or what does literature say? I mean, this is something you can never think of, right? I mean, when you showed, I was just kind of thinking it looks so much like Wilms, but yes, what is your, is the component usually a rhabdomyomatous component, or
primary testicular germ cell tumor, the somatic malignancy is not a very common thing. But once you have given you have taken out the testis, given chemotherapy for a retroperitoneal metastasis of germ cell tumor, in that you may have somatic malignancy developing. So especially the clinical thing is that you have a retroperitoneal node, say in a testicular germ cell tumor, who has been given chemotherapy and it is stable for some time. The retroperitoneal nodes have subsided, but they again start growing after some time. So there are only 2 possibilities. That's either it's a growing teratoma syndrome or it is a somatic malignancy which has arisen. Because in most of them, the tumor markers are negative in these. The tumor markers are normal in these, both conditions. Because they are something which is totally differently arising. Very rarely you may have mildly raised AFP in these even somatic malignancies. But these are extremely.
Yeah, they're very exceptional. Yeah, very rare. So you have
even more rare.
And rhabdomyomatous. We don't know. Maybe, like you said, teratoma giving rise to all these elements. That's probably the explanation, isn't it? We don't know. Now at the moment it's all a collection
of
of
stem cells.
cells.
Finally, every tumor is a stem cell, so you can always call it arising from stem. So there is some Conan's theory which is there, which I also came to know recently only
Okay.
when I was working also. I was reading about it and came to that there's something called a totipotency of embryonic stem cells, and they can differentiate to any variant with any
Great.
variant tumor. Like
Yeah,
that.
very interesting. Thank you so much, Santosh. Thank you.
Thank you, sir. Thank you, ma'am.
I'll move on to the second case.
Yes, sir.
So this is a 26-year married lady with acute abdominal pain. She had recent onset amenorrhea. So married lady, amenorrhea, acute abdominal pain. The clinical triad is very classical of an ectopic gestation, and that was what was clinically thought of. An ultrasound abdomen was showing query torsion of ovary, query ectopic. So there was something which was bloating up in the adnexal of the area, so they didn't know whether it's ectopic gestation or just a torsion of ovary. An emergency laparotomy was for query torsion was done, and ovarian tissue was sent in bits and pieces. So I'll directly go to the microscopy here. A very busy looking cellular tumor with a lot of hemorrhagic areas. Very blue looking at this power. Not much details can be made out at this power. Again, hemorrhagic areas just to show that there is fibrin and a lot of bleeding which might have occurred internally in that patient, along with this kind of fragmented tumor which was sent bits and pieces. Higher power, you can see that these are again very strange looking cells. Some are little smaller, some are larger, some have this smudgy looking nuclei. Hemorrhage, again you can see them. Other areas which can be seen here is these more blue and smaller cells but little monomorphic. They are little cuffed off by these multinucleated giant cells, which you can see if you can appreciate at this power. Maybe at other pictures you may be appreciated. So it's kind of a morphology in which you have two kind of cells: larger cells with multinucleation, and these kind of cells with mononuclear kind of cells. Again, at other areas you can clearly define and clearly defined multinucleated cells with many nuclei in them, and then there are some cells which have more cuboidal cytoplasm, more pink looking cytoplasm, vacuolated at places, and this cuffing of giant cells over these clear to cuboidal eosinophilic cells was seen. Other areas, again, to appreciate these multinucleated giant cells and these monomorphic cells. More areas to show similar picture of admixture of so there was kind of a biphasic pattern or a plexiform pattern. You can see that they are intermixed with each other. At many places these multinucleated giant cells are covering these smaller cells which are appearing rather spindly at places. More areas to where they look more epithelioid but with monomorphic appearance, eosinophilic cytoplasm, vacuolated. But again, there are a lot of multinucleated giant cells which you can very easily appreciate in this picture. More higher power picture to show the similar findings. Very glassy appearance at places of these cells here. Cytokeratin was strongly positive in these cells, and GATA3 was positive. I think morphology is pretty classical if you look at these plexiform arrangement of these trophoblastic cells, of syncytial trophoblastic cells and the cytotrophoblastic cells here, and the classical history of amenorrhea. So this was a primary ovarian choriocarcinoma, again an extremely rare finding. So this was the final diagnosis which we gave. The question was whether this is a gestational choriocarcinoma or is a non-gestational choriocarcinoma. This is a question which sometimes may not be answered. She had amenorrhea. She was married recently, so it's possible that it was a gestational choriocarcinoma. In non-gestational choriocarcinoma, it basically arises from germ cell elements. So you may find embryonal carcinoma, dysgerminoma, or other germ cell elements. So if you find them, that's definitely a non-gestational choriocarcinoma. But otherwise, when only choriocarcinoma is present, it's difficult to distinguish between these two. The treatment implications are very profound in these cases. The germ cell tumor-associated non-gestational choriocarcinomas are treated as germ cell tumors with BEP therapy, whereas gestational choriocarcinoma can be treated with etoposide, single agent methotrexate etoposide, or a combination which is totally different from this therapy. It is important to distinguish the two, since non-gestational choriocarcinomas have been found to be resistant to the single agent chemotherapy and have worse outcomes. The problem is with history, it's impossible to generate. In general, a patient who is sexually immature or unable to conceive or who has never engaged in sexual intercourse is obviously deemed to have a non-gestational choriocarcinoma, but otherwise it may or may not be true on the contrary. So there is some molecular jargon. I call it jargon because we don't understand most of it. At least I can't make out much of it. I don't do too much of these tests here. So the basic idea behind differentiating non-gestational choriocarcinoma and gestational is by using specific short tandem repeats in the DNA and detecting the paternal allele. So if you find something of paternal origin in the tumor, then basically it's a gestational choriocarcinoma. That's what my understanding from this is. So this was a paper in Journal of Ovarian Research which had looked up this, and this is the complicated test which they do of the patient. S stands for the spouse and T stands for the tumor. So they do a detailed DNA analysis of the patient, the tumor as well as the spouse, and they look for the paternal alleles by sequencing, and if they find certain specific short tandem repeats which are specific to the paternal alleles, then they would label this as a gestational choriocarcinoma. So that's a short case. It's an extremely rare case of choriocarcinoma of the ovary, or primary choriocarcinoma of the ovary. So I thought I would like to share this. Any questions,
Thank you.
Nadusha?
Thank you, sir. Thank you very much. I have one question, sir. What was the beta HCG level pre-op? What was the surgery done for this lady, sir?
It was an emergency laparoscopy because she presented with acute abdomen.
So it was ovarian.
Yes, it was ovarian because they found that there was ovarian gestation. So clinically they thought of an ectopic gestation. Married recently with amenorrhea and presenting with acute abdomen. I think the first possibility clinically was ectopic gestation only.
Okay. Right.
I don't remember the beta C, but I'm sure it must be raised because
it must have been raised, definitely. Right. Okay. Thank you, sir. Thank you.
Questions? Nadeem, sir.
Same question was asked by Dr. Hema Chandan on YouTube. Beta HCG level.
Beta HCG, I think, was raised in any case.
And he also had a comment on the previous case, which I have forwarded to Dr. Suma on her WhatsApp. She can read it out.
I don't see that, sir. Have you? Okay, it's there. That is from Hemachandran Mani Kapurat, right, sir?
Yeah.
And he says post-chemo retroperitoneal residual tumor commonly seen is cystic trophoblastic tumor. How often you see rhabdomyoblastic differentiation? I think he's talking for the previous case.
Previous case, he's asking about rhabdomyosarcoma.
Post-chemo retroperitoneal residual tumor commonly seen in cystic trophoblastic tumor. How often you see rhabdomyoblastic differentiation?
Cystic trophoblastic tumor is just a benign condition in which you have multinucleated cells lining cysts with a lot of acculation. So that's generally a benign condition. If you pick it, we put it in the report just like that. But rhabdomyosarcomatous element, like I said, is mostly a post-chemotherapy chain, more often seen in retroperitoneum of treated germ cell tumors of testis. So in a post-chemotherapy case, if you see that the retroperitoneal tumors retroperitoneal mass is increasing in size with the markers being normal, I think that should raise the possibility of somatic malignancy.
Okay. Thank you, sir. I think
we'll go to move on case, to the next. We'll move on. Yeah. Case number 3 is a 20-year-old girl who presented with bleeding PV since 8 months. She was suspected and diagnosed to have a fibroid uterus clinically as well as on ultrasound. They went inside with the uterus was bulky, and they removed the fibroid as a myomectomy. The patient underwent uterine artery embolization also, but had persistent bleeding. CT and abdominal pelvis later on also showed that she had ill-defined mass involving mid and lower uterine segments and cervix, causing hydronephrosis also. And there were certain external iliac lymph nodes, some of which were very large. So this was managed outside completely. We have not much about what was done outside. But after myomectomy, she presented to us with all these findings, and she underwent a THBSO and PALT. This was also all done outside. So we got referral material from outside. These were the findings which we saw. And this was the microscopy of the few blocks which were sent to us. So you have a tumor which is very well seen permeating the myometrium. You can see very nicely punctated arterioles, and you have a very little blue-looking cells which have little pink background within them, which are permeating this myometrium. At other areas, you can see these little whorls of more pink cells cells and little blue cells, again with very, very punctated and regularly interspersed arterioles. Very classical picture of certain things, which I'll come to later. Some higher power to show those little more pink looking whorls with pink cytoplasm, a little more more blue looking cells cuffing off them here. There were certain other areas which were submitted, which were more blue in appearance, more cellular, more busy looking cells piling up on each other, again, but punctated by these smaller, less thicker arterioles, I would say. More blue looking areas, more undifferentiated and blue or blue round cell kind of appearance, again, arterioles, little edematous areas in between them. This is again to appreciate that in contrast to what we saw in the other pictures, which looked very pink and very bland with whorls and all. These are more blue looking areas with more compact appearance of the cells. They were adjacent to this more pink looking. So there were these more pink and low grade appearing cells and this a little more high grade appearing cells with necrosis. So they were adjacent kind of areas sitting next to each other with this kind of appearance. More appreciation of the more blue looking areas. Certain sections made them look pale. They had interspersed capillaries, almost throwing them into a vague nested pattern. Again, you can see little nested pattern of these cells with very fine capillary network between them. There was some mitosis and apoptosis in these areas. So our possibility was an endometrial stomal sarcoma. We did think of this. We did a cyclin D1, which was diffusely positive in these areas. Again, you can see that cyclin D1 was diffusely positive in these blue looking areas. But if you look at the intermingled areas or the demarcated areas, the pink looking tumor cells which had more bland appearance with tumor whorls, they were less cyclin D1 positive compared to the more blue looking and round blue looking areas which had more capillary network. So they were kind of two different looking areas in this, and the cyclin D1 was also different. So we were thinking, is it a high grade ESS or low grade ESS? So if you look back at the morphology and go by the literature, when you see these blue looking areas lying adjacent to more fibroblastic appearing areas or more pink areas or fibromyomatous areas, then we should definitely think that we are dealing with a high grade ESS, especially when cyclin D1 is diffusely positive. So we did definitely think of high grade endometrial stromal sarcoma in this case, and this is some literature which has come in last few 6 to 7 years. There is a category of YWHA translocated tumors, endometrial stromal sarcomas, which are clinically more aggressive, and they have been labeled as high grade, and recent WHO has also included. So these are been renamed as YWHA NUT M2 fusion high grade ESS. This is the seminal paper, the first paper which described this. So they had these pink looking areas and the blue looking areas adjacent to each other. The classical description is of a low grade fibromyomatous, low grade endometrial stoma sarcoma areas which are lying adjacent or intermixed with areas which have a round cell morphology with a prominent capillary network. So this is a picture from the same article which shows a 1017 translocation, which is characterized of this YWHA NUT 2A. So they have different kind of ways. So biphasic pattern with a low grade component and a high grade component is characteristic of this high grade ESS areas. Prominent thin walled capillaries are seen in high grade ESS in the round cell component. So those are the two most important pictures, things which should come to your mind. Recently, there have been another set of high grade endometrial stromal sarcomas which are characterized by BCOR alterations. They may be BCOR translocated or internal tandem deletions may occur in BCOR, and the BCOR IHC can pick these tumors. So why should we pick these up? Because these are clinically more aggressive than low grade ESS, and they have now clearly been categorized as a defining feature of high grade ESS. Other IHC profiles which you may encounter in YWHA ESS is the cyclin D1 I've already shown. CD10 may be patchy or diffuse. CD56 and CD99. We had not done this in this case, but literature does say that CD56 and CD99 comes specifically in these kind of cases, which is very, very difficult to reproduce sometimes because CD56 is such a non-specific marker, and they may be variably ER and PR positive. So in this current case, we did a YWHA NUT M2A. We do have this this FISH probe with us, and you can see that the red and green signals are translocated. So we reported this as a YWHA NUT M2A translocated high grade Yeah, ESS. These are some other pictures of a low-grade ESS just to complete the teaching. You can see that this permeative pattern of ESS is very, very characteristic, and most of them would have several lymphovascular emboli. The arterioles are very prominent in this tumor, which are very, very nicely seen in most of the endometrial stromal sarcomas. Almost all of them would have a similar pattern in low-grade ESS. So these are some pictures. There can be some variability. Some may look more pink. Some may have a smooth muscle kind of starburst pattern in them. Some may have a very thick-walled arterioles, which may look very prominent, and some may have a little papillary appearance at places due to some cystic degeneration. CD10 can be positive. Is usually very diffusely positive in low-grade ESS, but in high-grade areas, ESS like YWJ and BCOR, it may be variably positive. Again, you have set of sex cord tumors which have you have low grade ESS which can have sex cord elements within them, and they have been variably labeled as uterosat or estical. So this is again another fault. So in some low grade ESS, you may find very focally some cord like or reticular pattern of cells. If you do an inhibin and WT1, they turn out to be positive. So they can be, you can have those kind of variations in them. But this case was basically shown that one, if you have a endometrial stromal sarcoma which has got fibromyomatous low grade areas juxtaposed to areas which look very round cell in appearance with capillary network and which is cyclin D1 diffusely positive, you should definitely think of a YWHA translocated high grade ESS.
Thank you, sir. I think that summarizes that last few points, whatever you told, that kind of pink areas adjacent to the round blue cell area is the one should be a clue for us to think whether this is a translocation induced tumor.
And obviously, general high grade would have more mitosis, but unfortunately, we don't have cutoff for mitosis to distinguish.
Right.
I think a battery of IHCs like cyclin D1 and CD56, CD99, and obviously a molecular test to confirm would be required in such cases.
One thing, the age is only 20 years, no, sir. That's what you said. She is quite young.
It's quite young, yeah. So I think we have seen ESS and as young as I think 17 and a half.
Okay.
The youngest that at least I can recall of high grade ESS. So ESS, not high grade ESS. ESS.
ESS. Yes. Right. Thank you, sir. Thank you.
Any questions?
No questions.
There is one from Dr. Vishal Rao. He says cyclin D1 do help in these cases, he says. And that's what you have done, I understand, right, sir?
But negative cyclin D1 does not rule out these cases. So the confirmatory tests are always molecular in these confirmation for confirmation. So unfortunately, they are not available everywhere. But yeah, morphologically, we can definitely suggest, and we can do a battery of markers like CD56 and MIG2 in these cases. So they are in literature it says that CD56 and CD99 with cyclin D1 is pretty much specific for YWJ. I personally have never used. Pardon?
Is it like when the histology is looking low grade, but you are getting cyclin D1, should we suspect this? I mean,
see, if you do cyclin D1 is again a marker of cell cycle, so it can come in few cells. It has to be diffuse and nicely strongly positive. So then only you start suspecting high grade actually.
Okay. So when it is diffuse and strong, we should suspect that, right?
Santosh, what about the age? Do we have another high degree of suspicion if the age is, I mean, if it's a young patient? I mean, what is it?
No, madam, no. The problem with these tumors clinically, I'll tell you what the problem is. These are suspected to be fibroids. So they go in and they do a morcellation sometimes. And sometimes it's not, the morcellation is not in a bag, and then you have the issue of spillage into the peritoneum, into the abdomen, and that's a big issue because these are sarcomas, and if one of them turns out to be a high grade ESS, then the patient is completely doomed because if it spills onto the peritoneum, the whole peritoneum gets flooded with these. So in general, these days laparoscopic surgeons would deliver these kind of suspected myomas into a bag and then morcellate a tumor within the bag, so that if there is no spillage in any case. So even if it's surprise ESS turns out fine in the final report, they still have clearly maintained the breach. There is no breach of that spillage spillage into the abdomen.
On sonography, can we have a suspicion of this?
ESS? No, sir. I don't think they look like myomas, sir.
Do they look like myomas? Also, the vascularity is same as myomas?
I really don't know whether radiologically they do a Doppler in these and pick up that they have more vascularity and they suspect that it is seriously. sometimes with these findings, if you have say thrombus of the iliac veins, then because these are known to invade the vessels and cause thrombosis of the vessels. So if you have thrombosis of these veins in the pelvis, then you can definitely say that probably this is a ESS compared to an intravenous leiomyoma, or which is not very common.
Dr. Hemachandran has a comment. I will just read that out.
Yes.
Were the pelvic lymph nodes positive?
I don't remember him, Chandra sir. I think they were positive. I think. Yes. I think we did not get them because this was a block which was sent to us. So this was a tumor which had come out from us. So they had done everything outside because in TMH they would not have done a THBSO for a 20-year-old without having a working diagnosis beforehand. So this was a case which had come from outside. We had very limited blocks from this.
Santosh, may I ask a question?
Please.
Yeah. Okay, so actually we've suddenly got a plethora of ESSs recently, surprisingly, and one case was something that had been reported as a low-grade ESS 2 years ago, and then the patient has presented with multiple peritoneal widely disseminated disease, and then we looked at what was reported earlier. So I mean, there were no clues to say that there was it was a high grade. So maybe sampling was an issue. Like you said that you can get low grade areas and high grade areas.
There are.
We did a cyclin D1 in one of those low grade looking areas, and it came very diffusely positive. So I think the message over here is that for all ESS, I think cyclin D1 is the must.
We are doing now, Vijay, we are doing that.
Yeah, and also there is an article by the same Esther Oliver group where they've also had a similar experience, and they in fact recommend molecular testing for all ESS, irrespective of whether it's low grade or high grade.
What they would do in the West, in the US at least, any ESS goes for JJAS fusion as well as YWK and BCOR.
Yes.
Now BCOR.
So I think it's time over here too that we send a message that especially if we are getting like morcellated specimens, then we should be doing, and if the cyclin D1 is very diffusely positive, then the patient must go in for a molecular testing for this YWHA fusion.
So I think over the last couple of years, at least, we are trying to do cycling even in most cases, unless it is very, very classical, typical, very typical looking ESS, low grade ESS. But again, like you said, the message is we should try and do cycling even this so that we are not to miss a high grade, which has got a very poor outcome compared to the low grade ESS.
Yeah. Okay. Thank you.
Move on to case number 4.
Yes.
46-year-old female, right head neck cell, who came with right head neck cell mass. Again, I think this was a referred case. Underwent cystectomy with bilateral salpingo-oophorectomy and bilateral pelvic nodal dissection. Ovarian mass was bossulated and measured 13 into 10 into 10 centimeter. The cut surface was solid with focal microcystic areas and some papillary excrescences. Capsular breach was seen. So this is a scan slide in our 3D histech scanner. It's a low power, you can see that. So at low power you can see that there are some follicle-like cystic areas, some very clear looking areas here, others are looking predominantly blue at low power. Higher power you can see that there are some clear areas, some very oncocetic appearing epithelial areas, some very, very tubular, glandular areas, very packed cellular areas, some kind of some material within the lumen, almost resembling mesonephric-like areas, but very clear oncocetic and glandular areas were seen. So this was a referral case from Delhi. Now I remember it pretty clearly. This is again showing these tubules and glandular areas, which you can see very thin capillary running throughout this tumor. This was the morphology. More areas to show the morphology. Very packed areas of these very columnar appearing cells at places. You can see, although not too much of cytoplasm, but the cells are just standing on the basement membrane here. Again, this kind of material within the lumina here. More blue areas, some different looking areas again. Here, and this is another section from a totally different looking areas, very oncocetic, almost resembling like an RCC, I would say, some kind of with very sharp borders. Some clear cells, some eosinophilic, some with Vespi cytoplasm, the nuclear, vesicular, multiple kind of nucleoli in certain cells, but otherwise monomorphic in appearance, not very, very pleomorphic, not too much variation in the nuclei of these cells. Again, to show that there were more cells with larger amount of cytoplasm, clearing of the cytoplasm, but some oncocytic appearance at these areas. Going back to the tubular areas, there were more solid appearing areas in certain tubular areas or follicular areas, you can say, mitotic activity, and these are more sheeting pattern of these very vesicular looking, very but not very prominent nucleoli in these areas. At other areas, there was a decent amount of hob-railing. If you can appreciate the cells lining, they are just jutting into the lumina here. Solid areas with necrosis were also seen at places. Higher power to show this the morphology of the tumor cells and the nuclei. Again, a mixture of little blue cells with little cytoplasm with more pink and oncocytic appearing areas. So this was the basic morphology: oncocytic areas, hob-nailing, tubuloglandular areas, and this kind of solid areas within the tumor. Other areas were more cystic with some fluidy material, and again, very this was in certain other areas. So we were worried. We thought morphologically these areas did look a little glandular and tubular. So a strong possibility. What we were thinking was these are some variations under endometrioid adenocarcinoma in the ovary, because endometrioid can have seriously very different kind looking patterns and different things. Several of our endometrioid tumors we have been foxed many times, and they've turned out to be endometrioid. So we did a PAC-SAID. PAC-SAID was nicely positive, but what PAC-SAID was showing that it's rather than long gland-like pattern, they were more like follicular appearing areas, very small kind of follicles, which was nicely marked by PAC-SAID. ER was negative, napsin was negative, WT1 was negative, inhibin was negative. We did a whole battery. I'm not showing the negative. Several negative things were there. We again went back to the morphology. Again, oncocytic areas, clear areas. We were totally foxed by this. We started looking at this material, what it is. Is it some mesonephroid tumor which can have this kind of colloid-like material or something? We vaguely thought that is it a thyroid kind of appearance, or is it a tumor arising struma ovariae or something? Because they were having this kind of material within the lumen. And again, there were some areas which had more of this material. Large cystic areas were present. TTF came out to be strongly positive in these tumorous areas, and thyroglobulin was also diffusely positive. During the similar time, we had another female who was 54-year with ovarian mass. We had more high-grade areas, but these tubular kind of areas with a lot of necrosis. Even that tumor turned out to be PAC-SAID and thyroglobulin positive. But in that tumor, what we saw when we took multiple sections was there were clearly classical areas of struma ovariae. Of thyroid follicles, and there was a range of findings from a thyroid follicle, normal thyroid like follicles with colloid changes, and hyperplasia, and this poorly differentiated thyroid. So what we were dealing with, we within the span of 2 months, we had seen 2 cases of poorly differentiated thyroid carcinoma arising in struma ovariae. This was the second case, which was also positive for TTF1 in addition to thyroglobulin. So in this, the index case which we are talking about, we asked for the history, whether the patient is a known case of CA thyroid, or we asked whether the patient was early diagnosed as tumor ovariae. We mentioned this, and we mentioned that the radiology of thyroid gland needs to be taken care. We came to know that the patient is in Delhi and was treated with paclitaxel and carboplatin. Even after our report of poorly differentiated thyroid carcinoma in ovary, they have not put the patient on radioiodine. That's what my last knowledge is. The important thing is it can pose diagnostic difficulties. In this case, it resembled an endometrioid adenocarcinoma. It is extremely important to pick up the thyroid type of cancers anywhere, for that matter, in the ovary or the testes, because to treat them and to treat the possible abdominal metastasis of these patients with radioiodine, you will have to first do a total thyroidectomy in these patients. So your diagnosis would implore or would tell the clinician that they need to go ahead with the thyroidectomy before they give the patient radioiodine in these cases. So that's the implication of picking up these findings. So this was a very unusual case. We had almost thought that we would sign it off as endometrioid, but again, you can call it a serendipity, or maybe we looked at it carefully and we thought that those colloid-like material was, and we did put a TTF1 and thyroid. So sometimes if you make a little extra effort with the immunohistochemistry, sometimes you can arrive at a different diagnosis with different clinical and management connotation. Any questions on this?
Thank you, sir. I just have a question. This lady had a thyroid tumor also, sir, at the presentation? How is it?
No, she did not have anything. This is not a thyroid metastasis. This is a primary poorly deficient thyroid carcinoma arising in a stroma ovary.
Okay. But you asked for to work up for thyroid thing. That's what you're telling.
Because the material was sent from Delhi as a referral material, and we didn't have the patient there. So we called them up and told them that we asked for history. But I don't think even after the history we have not been able to follow up too much after, because it's almost 2 years since that has been done. But ideally the patient should have undergone thyroidectomy before giving radio iodine.
Meds from thyroid to ovary is known, sir. Is it there in the literature?
Yes. I think thyroid can metastasize to many places, so I'm sure you would find it. It's not an issue. But this patient did not have in the thyroid, because they did that at least. That information we had. They did not. Any questions? Vijay, Sandhya madam, Vishal?
A very interesting case, actually. Dr. Suma said, first we have to rule out, but you said there was no thyroid this thing at all. It was directly arising out of the stroma ovary.
And other thing, Sandhya madam, it looked very much like we were literally thinking that we should call it a endometrioid, because backside was positive. We were happy that it's Mullerian.
No, but you did thyroglobulin and so.
Yes. TTF and thyroglobulin were diffusely and nicely positive.
Very interesting. Nice case. Thank you.
And also you have extensively sampled to look for other teratomatous elements, right, sir? I mean, that's what you have to rule out teratoma.
The blocks had come to us, so we have suggested all that in our report. But whatever we had got was a poorly differentiated thyroid carcinoma.
Right, sir. I don't see. Dr. Vishal Rao says it's a nice case, eye opener.
Okay, thank you, Vishal. Thank you so much.
I think we can move to the next case now.
Yes, case number 5.
For the patient to get the thyroid out would be a very difficult job.
But sir, we have seen, so this is a totally difficult case in the sense it's a poorly differentiated. But sometimes we have seen when we have reported, say a papillary thyroid carcinoma arising in a stroma, at least our clinician would make it a point, because they cannot give radioiodine with the thyroid being in the body. So they have to remove the thyroid to give thyroid here. And at least a couple of cases we have seen with which you have ovarian papillary thyroid carcinoma with metastasis in the omentum. So to treat the omentum and the metastasis and the micrometastasis, you have to give radioiodine to that patient. And without the thyroidectomy, that is not possible.
Yes.
Suppose you have a coexisting thyroid lesion, then
you would probably think of metastasis, sir.
Then
you have to definitely rule out a primary in the thyroid in that case.
Right.
Yeah.
Interesting.
Very interesting.
Thank you. Thank you, sir.
Yeah. Case number 5. So this is a 45-year-old female presented with hematuria on and off since 2 months. CT scan revealed a heterogeneously enhancing mass in front of the left lateral wall of urinary bladder. So now you might imagine this is a GYN Path slide seminar and I'm talking of urinary bladder, but I just couldn't keep my hands off of uropath also here. Anti-rhabdomyosarcoma wall. So there was thrombus formation at the IVC junction which extended into iliac veins. There were few enlarged perivesical and left external iliac nodes and few tiny nodules in bilateral lung parenchyma. The patient underwent radical cystectomy, but before radical cystectomy, we had a TRBT. This is a picture from the TRBT, looking very cellular and busy here. If you look at low power, at higher power, you can see very monomorphic cells, absolutely monomorphic in a very hyalinized and very pink-looking stroma at this power. Again, little more myxoid appearing areas, very monomorphic. There is hardly any pleomorphism. You would think what kind of tumor is this? We really wondered. Never seen such a TRBT ever in my life. So again, a little more grouping of these cells, maybe a little cording and trabecular pattern. Again, very hyalinized and pink looking stroma. Some cells have little clear cytoplasm, kind of a halo around them, or a clear, whatever you can say. But it kind of embedded in this hyalinized matrix. Higher power to show the morphology of the tumor cells better. Clear cells, couple of them were binucleate. So we were totally fogged. We had no clue what we were dealing with. We did not understand. And when we don't understand anything, we don't have a clue. We just put some random IHC markers, and that's what we do. We had absolutely no idea on morphology what we are dealing with. It was a bladder tumor, so we did A1, A3, we did a GATA3. Is it some funny looking chordoid urothel tumor? We didn't know because the background was myxoid, hyalinized. Paxate was negative, MIG2 was negative. We just, to be very frank, we did some random markers because morphologically it did just look like it's some low grade sarcoma, very monomorphic, embedded in a matrix. So is it a matrix producing tumor? Is it? So we did these kind of markers. We did Desmin, which was negative, CK dog 1, because couple of gist we have seen in the bladder, but those are mostly typical gist with spindle morphology. That was again very round epithelioid morphology, clear with clear cytoplasm in it. But CK dog 1 was negative, S100 was negative, SMA sometimes you can do becomes nuclear positive. It was non-specific again, so we had no clue. We did a Vimentin just to put in the report that something is positive. So Vimentin came diffusely positive. So this was a cellular tumor with short spindle to overt cells, very low mitosis, no necrosis, no nuclear atypia. We really didn't know what to call it. We thought that it's a decently big tumor. So we discussed with the clinician that probably it's a sarcoma. It may be an intermediate grade sarcoma. We don't know what it was because the mitosis was not very high, but the tumor was completely filling all of the TRBT checks. There was hardly any area which was not filled with tumor. So we sort of discussed with the clinician and said we might be dealing with an intermediate sarcoma. So they did a radical cystectomy and we had a radical cystectomy. The tumor was in the blood walls and this was the low power picture of the tumor. You can see how it is present. So it is sort of permeating all the layers of the bladder. You can see the perivesical fat. You can see the tumor thrombi within the lymphovascular lymph spaces. It is completely permeating the detrusor muscle bundles and invading into the perivesical fat. This is another picture to show how it was invading the wall of the bladder. This kind of the same monomorphic appearance of the tumor with hyalinized stroma, similar to what we saw in the TRBT sample. And see, it's not actually destroying the detrusor; it's just permeating it through it with nodular formations, very uniformly spread tumor cells within them with very hyalinized stroma, similar to what we saw in the TRBT. Again, to show those areas, a little more spindly appearance with little taper end, but very small nuclei as such. Again, to show those areas with hyalinized stroma. And then you had areas similar to what we saw in the TRBT with little kind of halo around the nuclei, little clearing of the cytoplasm, probably, and very hyalinized looking areas. So diagnose. If you look at the radical cystectomy, it looked very much. So supposing this was a uterus, your diagnosis would be spot on. Any tumor which permeates the myometrium like this, the only thought process which would come to your mind is then again a endometrial stromal sarcoma. So this is again a tumor which is completely permeating the muscle, and this is what we thought. The nuclei looked very bland. The stroma was variable from myxoid to hyalinized with kind of clear. So we really thought, looking at the gross on and looking at the microscopic pictures of radical cystectomy, is it an ESS? We did an ER, AR, and CD10. All of them were strongly positive in this case. I think CD10 was not great, I must say, but these markers were positive. We went back and asked for the history. She had undergone hysterectomy a few years back for dysmenorrheic complaints. No histopathology details were available. So we were thinking, is it an endometrial stromal sarcoma of the urinary bladder? Mind you, the history also had that she had iliac vein thrombosis, and there were thrombosed veins in the pelvis. So that's another clue in such cases. Very few cases have been described of endometrial stromal sarcoma involving the urinary bladder. We did our JJASF fusion and translocation markers fish, which we have, and we found that there was loss of green signals in many of the cells. So this is again a very rare case of endometrial stromal sarcoma. If you look at this case series of 6, they also had abundant keloidal collagen formation in few of their cases, which involved the urinary bladder. The issue is that many of these tumors which present in the urinary bladders would present after several years, and the patient may not even remember the history of hysterectomy or may not remember. This patient, I think, had undergone hysterectomy about 7 to 10 years back, if I remember correctly. So this was a strange looking endometrial stromal sarcoma low grade which was present in the urinary bladder.
Thank you, sir. We should consider this as a mets from, suspecting that her uterus had this tumor earlier. Should we think like
Yes,
that?
yes, Dr. Suma, that would be first possibility. The other thing is maybe she had widespread endometriosis, and this endometrial stromal
Okay.
sarcoma has arisen
Okay.
on a background of endometriosis. So
Okay.
that's
Okay.
bladder endometriosis is not very uncommon.
Okay. We also have heard of primary endometrial stromal sarcoma in the peritoneum right now, sir. I think the same kind of explanation can be given in
Yeah,
that also.
most of them are endometriotic foci which have totally endometrial.
Okay.
Yeah, very
Okay,
small
okay.
burnt out endometriotic foci in which the stroma becomes sarcomatous.
Okay, okay. Right, right. Can there be any other site apart from these two, extrauterine where we can get like this kind of stromal sarcoma, sir, like endometrial type stromal sarcoma?
Uterine endometrial stromal sarcoma is described everywhere in the abdomen, on the bubble wall, bubble loops. They can form,
Okay,
and on the surface of the spleen. So they've all been described.
okay. Right.
Be on a background of endometriosis, widespread endometriosis.
Okay. Thank you, sir.
Any questions, Nadeem sir?
There is a comment on the YouTube which I've passed to Dr. Shuma. She can have a look and then she can put it up.
Okay. Um, Dr. Minesh Gandhi, I don't know, maybe he was commenting for this case, he thought MUC4, I don't know why he mentioned MUC4 there. And
No clue. Maybe
I
you
don't know,
think
there's
that's
no,
sarcoma.
maybe he was thinking that. Maybe SCS, I think sclerosing epithelioid sarcoma, he thought based on the morphology probably.
Sclerosing epithelioid. I think we did decimal morphology.
Yes, right. And Dr. Sandhya ma'am thought probably it was a chondroid, as you also mentioned that you also felt that was a chondroid when you were looking at the TRB chips.
Yes.
It had that chondroid kind of areas.
So
Right, sir.
we'll move on to probably the last case. Case number 6 is a 20-year-old female. She's married and she had LSCS recently, and last childbirth was 1.5 years. And after her last childbirth, she had not menstruated after the cesarean. Heterogeneously lobulated mass was seen in the uterus. Bilateral ovaries were not separately seen, so they really didn't know whether it's an ovarian mass or a uterine mass, because it was kind of a big mass in the pelvic cavity. There were multiple enlarged lymph nodes in the peripancreatic, para-aortic vessels areas along the iliac vessels, encasing the aorta and IVC at places. The tumor markers provided from the referral was that AFP was 4.3, CA 125 is 32.4, LDH 1200 units per ml, and CA 99 was 58.63. This was again a referral case. The patient had already received one cycle of CHOP. I really don't know. There were no details available. She was treated somewhere in Bangladesh with one cycle of CHOP. And again, because they really didn't know that whether the mass is from the ovary or the uterus, they gave her 3 cycles of BEP. So she came from Bangladesh to us with this kind of history, with a large pelvic mass, query ovarian, query uterus, one cycle of CHOP thinking that it's a lymphoma, and 3 cycles of BEP thinking that it's a germ cell tumor. I think LDH was raised, so that made them think either of a lymphoma or a germ cell tumor, and she was treated based on that without a proper tissue diagnosis. So what we did, the biopsy was taken from the pelvic mass, and this is what we see. They look like prostate cores, but they are not prostate cores. They are from a female with a pelvic mass. You can see that these are very pink, smooth muscle bundles, probably from the myometrium at this power. If you look at it, again, cores of tissue which were taken per abdomen, and you can see there is some more blue looking area here. So these are definitely myometrial bundles with hyalinization in between them, and then there was this kind of histiocytic appearing foamy cells within it. Remember, she has multiple cycles of chemotherapy. She has not menstruated after her last childbirth, which was a cesarean section. So that's a history which was provided to us. Again, you can see the myometrium, these kind of cells looking extremely bland, monomorphic at this power. Another fragment to show very monomorphic appearing cells. The cytoplasm is decently, I'll say, moderate to abundant at this power, but very monomorphic nuclei, small nuclei, no pleomorphism at this power. Higher power to show these cells with pink cytoplasm, some with vacuolation, fuminess, very monomorphic appearing cells again, some blood vessels here with RBCs you can see interspersed within them. Again, showing the sheets of cells in this very tiny core, uh, a well-defined cytoplasm at places, very wispy pink eosinophilic cytoplasm, some with more bubbly and vacuolated cytoplasm. Other areas within the myometrium, small collection, more clear and vacuolated cytoplasm of these cells, but again, no, not very pleomorphic nuclei. Some pigment, query hemosiderin, we don't know what it is. Again, very fominous, this fominess of the cytoplasm of this very monomorphic appearing. So what it appeared to us that are we dealing with histocide because she has had LSCS, she has had chemocycles of chemotherapy, CHOP or BEP, what are we dealing with? So we did some ICs, you can see that there is some brown here, there is some brown here, there is some brown here, nice brown color of IHC. Some probably muscle marker done, which is showing this muscle. This looks negative. Some nuclear marker which came positive, so I'm keeping a little suspense here. Again, nuclear markers positive and some another marker negative. So what came positive and what negative? So seriously, we did think that this was histocytic proliferation also, but just because it's a huge tumor mass and she's got multiple nodal metastasis, tumor is everywhere. We thought with this morphology we did. If you thought that this is CD68 or CD63, you may be wrong. This was HMB45, which was diffusely positive in these tumor cells. We can see that this very nicely positive in the tumor cells, HMB45. Desmin was negative in the tumor. You can see that the internal control of the myometrial fibers is nicely positive. The tumor is negative here. If you thought that this nuclear marker is MIB1, ER or PAX8, you may be wrong. This was TFE3 positive, which is nicely positive. So again, to show that TFE3 nuclear positive, S100 was negative. So this is a peripecoma of the uterus, which is malignant because it's already spread to the lymph nodes, and it's a TFE3 positive. So generally, these perivascular epithelioid tumors of the uterus are positive for smooth muscle desmin and melanocytic markers. They are myomelanocytic tumors, but there are certain subset of pecomas of uterus which are negative to weakly positive for muscle markers, but they are strongly positive for TFE3. So this was an unusual case of a pecoma of uterus which is malignant. Generally, pecomas are either benign or of low malignant potentials. Malignant are rarely described, which is TFE3 positive. They look so histocytic sometimes that you may miss them. Actually, the idea to pick them is sometimes they look like ASPS, and ASPS is also a TFE3 positive. So sometimes when you see histocytic tumors in the uterus, you should definitely run a melanocytic and muscle markers and TFE3 to diagnose these. Some literature about them. These can fox both the gynecologist and gyne-oncologist. A literature review showed that 71% arise in the uterine body and others arise in the cervix as well as the adnexa. They are not too uncommon, but they are not common too. The problem comes with the treatment of these tumors, and especially the TFE3 gene rearranged pecomas. They may not respond to mTOR inhibitors, which are usually given for other pecomas, and they may require other targeted specific therapy like MET inhibitor therapy like crizotinib. So these may be mistaken, especially after the history of multiple chemotherapies, of a history of LSCS. You may think that these are histocytic cells, but then must keep in mind that a large tumor in such locations may be a pecoma. These are certain criteria which have been put forward in the same article by Falp as well as Schoolmister, and the general features are that the size of more than 5 centimeter, infiltrative and high grade nuclei with higher mitotic rate should think of this. This is taken from the latest WHO Blue Book of female genital tract, and the main criteria for malignancy is when you have more than 3 features of more than the size, mitosis, and necrosis and vascular invasion. I think I'll stop here, Nadeem sir, and I want to acknowledge my department colleagues, my gynae path DMG colleagues, Dr. Kedar and Dr. Bharat Riki in particular. I definitely want to give a lot of thanks to my clinical colleagues. Their clinical acumen directs us. Our patients, we should never forget, because we learn from their distress so that we get wise for the future. And I want to thank my residents because their questions keep on challenging us. Thank you very much.
Thank you very much, sir. That was interesting, really interesting.
Any questions, Nadeem sir?
I just had one question for the last case, sir. In your case, you called it as malignant Pgimer based on Ki67 and the size by imaging wise, sir? Because it
Right,
was a
it was
biopsy.
metastatic. It was everywhere metastatic. Radiology was showing it. All nodes, all retroperitoneal nodes were positive. Everywhere it was disease. So I don't think we need anything else. It's already spread everywhere.
Okay.
Dr. Santosh, what made you do TFE3 positive? I mean, TFE3 staining is.
We did. No, so we got HMB45 positive. After that, we did Desmin and SMA and all, which were all negative. So once you have HMB45 tumor in the uterus, melanomas are rare, and the morphology is not like a melanoma. You have to think of Pgima, and a Desmin SMA negative Pgima is usually TFE3 positive. So that's what made us do it.
Right. Okay. And could the initial chemotherapy could have made it a malignant lesion? I mean, is there any possibility to say that? I mean,
because it was just a couple of months back she had received chemotherapy.
So maybe originally itself it was only this. I mean, malignant picomas are.
TFE3 in the kidney, the TFE translocated RCCs which develop, they are known to occur after long years after chemotherapy. The same is not exactly true for picomas of the gynae tract, I think.
Very interesting. Thank you.
If it is benign Pgima, sir, I think upfront surgery is the treatment of choice, is it? Is it?
It's a big benign. The problem is you cannot diagnose them preoperatively. It's extremely difficult.
Yes, that's true. Yeah.
Into tumors which are arising from the uterus. You generally don't do that. Matter in the ovary also, you don't put your needle or do an FNAC. Unless until it's already spread to the omentum and all, you don't put your needle. Third time the diagnosis is post-operative. Any questions?
There is a question, in fact, a clarification. First thing is Dr. Minesh Gandhi at the very outset had said this is a Pgima. He had given a comment there. So that was good. And then he asks a question. He says, does soft tissue Pgima and gynae Pgima have different criteria for malignancy?
I think so. If you look at these are gynae specific criteria. If I'm not mistaken, if whatever I have put it here, there are some gynae specific, modified gynae specific criteria. So these are general criteria for Pgmas, and these are some gynae specific criteria. That's what is the current WHO book mentions.
All right. Right.
Right. It says, the table says for uterine perivascular epithelioid cell tumors.
So this is the general criteria, and this is the modified specific. I think it's taken from basically schoolmaster only. So because he is the author of that chapter in the WHO Pgima chapter.
Okay.
Any questions, Nadeem sir?
No, the wonderful presentation. I mean, Dr. Suma wants to add anything, then I'll come in if she wants to say anything.
Thank you so much, sir. Thank you, Santosh, sir, for showing us all these cases so that we'll keep this in mind, and when we are seeing, if we encounter, I think we can always remember these points, whatever you have told us. And excellent set of cases, sir. Thank you so much.
Thank you so much. Pleasure is all mine.
There are some comments here on the Google Meet. I think it's important for us to read them out. Dr. Vishal Rao, thank you, sir, for all the good cases. Dr. Seema Kaushal, very nice cases. Dr. Santosh.
All my friends.
Saeed, thank you so much. Interesting cases. Madam Sandhya says thank you, Dr. Santosh. Then on the YouTube, we have Dr. Minesh Gandhi, excellent presentation. Dr. Hema Chandran, very nice cases.
Hema Chandran is my teacher. I think I should acknowledge him a lot.
Sorry?
I've learned a lot from Dr. Hema Chandran. Dr. Hema Chandran is my teacher from PGI. Yeah, he's my senior from there, and I need to acknowledge him for a lot of things I've learned from him.
Yeah, right. Rajendra Lalani says, thank you, sir. Very interesting and rare cases. So, Dr. Barnek also says, good cases, sir. We have a lot of people, acknowledging. And yes, it was wonderful presentation. Excellent cases. Really eye-opener to all of us sitting in the peripheries here. And sometimes a bit scary as well.
It is scary. I agree with that comment a lot, because sometimes what happens is in the periphery you don't have the setup for IHC and all. Even in a setup where we have IHC, sometimes we underutilize them. And my point is we should probably go the extra mile sometimes to to really characterize the tumor. Just leaving them as mesenchymal tumors may not help the clinician in the current era. And in the coming era, where everything is getting targeted therapy and all, I really think we'll use more and more of IC and molecular to delineate these entities.
Yeah, many a times we feel that with all this, what you have shown us, that all so many things which we are trying to be so aggressively teaching our residents that this may not be that.
May not be that, sir. Yes, yes.
True. I mean, things are evolving very fast, and it is so good that this is I think the good part of having this online activity where you can share so many things and experiences, because it would be very difficult to host everybody in a place physically and discuss all this with so much frequency, and get to know so many things at a very leisurely time. I think all of us are relaxing in our bed or sitting here and there and listening to and still getting into understanding so new things. Dr. Neeti Goyal says, thank you very much. Learned a lot, sir. Really, we all learned a lot. Dr. Santosh, thank you so much for taking out time from your such a busy schedule. I think we are all now in the post-COVID time. Everything is normalized. At least in Calcutta it has. I think in Mumbai also it has. And
in person, we hope we can meet this in person someday.
Yeah, sure, we would. And I would like to thank Dr. Suma for taking out time to moderate this session, wonderfully done. And to thank all those people who are here, Dr. Sandhya and Dr. BJL Kulkarni and Dr. Nuzhat Saeed, Dr. Vishal Rao, and then so many people on the YouTube, more than 35 people on the YouTube there. And then overnight, maybe a lot of people would be watching it and seeing it and cursing themselves for missing the online live show, because they would have so many queries on this. Thank you, Dr. Santosh. Thank you, everybody. Good night. Take care. Bye-bye.
Thank you. Thank you very much, sir. Thank you. Good night.
Bye.